Jollies.tm features rush delivery, 1 hour. In-store pickup, regular delivery, 5 p.m. Cut-off time, 4 p.m. It's your time to jump the line. Visit us at www.jollies.tm. Jollies Pharmacy, leading the way in healthcare.
Jollies Pharmacy is bringing vibes to health with Health Vibes. Health Vibes. Each and every Wednesday from 10 to 11:30 a.m. with your hosts, Trudy Kristen, and co-hosts pharmacists Jacinta Fagan and Leona Jeremiah. Education, information, and a bit of humor. And not forgetting lots of vibes. Jollies Pharmacy is bringing health and vibes together with Health Vibes. So be sure to tune in each and every Wednesday on Q95 from 10 to 11:30 a.m. Jollies Pharmacy, leading the way in healthcare.
Good morning, and welcome to another episode of Health Vibes. It is your favorite Jolly's crew in the house this morning on a Wednesday, as you are used to. My name is Trudy, and in studio with me this morning is Jacinta. Jacinta, good morning to you.
Good morning to you. How are you doing? And good morning to our viewers and listeners.
I'm good, Jacinta. It is great, of course, to be here in studio to do another program. It is January, the longest month of the year. The longest month of the year. This is our fourth show for January. January always makes sure that all its 31 days are felt.
That's it.
And we are here with you on Health Vibes. We have been throughout the month of January. Of course, as we promised at the start of the year, always trying to bring you some aspect of health education that's interesting and has a little vibes. Good morning to all our regular listeners. I know there are many of you who join and listen to the program religiously on a Wednesday morning. Good morning to you guys. To those who typically view on the social media platform of Q95 FM, YouTube, and Facebook, good morning to you guys. I know that you all are, as usual, waiting for what we're going to talk about today. We have a guest in studio today, so we are very excited to have a guest and to have a topic that I think is maybe the first time that we will be, dealing with this particular topic. But so we're very excited. So if you're listening on radio and you can jump across to social media, do so you can see the guest before we even introduce her. But she's with us in studio. Jacinta, what is the mood like with Jollies? Carnival is approaching. It is almost February. As I said, January is, lingering, but it's almost February and Carnival is on the horizon.
Yes.
What's the mood like at Jollies with Team Jollies?
Well, as usual, we are very busy. We have not yet begun to feel the rush or the extra presence, of our lovely tourists and diaspora. But as usual, we are always bubbling, always exciting, always on the move, always, being challenged. And of course, you always welcome our regular customers. So nothing out of the norm, but we're always doing our thing.
Well, I know Jollies is of course doing its part in supporting the community, supporting Dominica and Dominica's culture by supporting some of the events. Jollies is a sponsor of the Dominica State College's Mass Jamboree, and tomorrow, Thursday, at the Dominica State College JP Mini, not many people outside of the college community know that there is a Jollies at the Dominica State College Stock Farm campus.
Yes.
It is JP Mini, and tomorrow at JP Mini, there's going to be a big vibes for the Mass Jamboree contestants. You get to meet them and greet them. DJ Rems will be there, and Jollies will be, of course, doing something nice for the patrons, a spin and win. So you get to come into JP Mini and spin a wheel and possibly win a prize or a ticket to DSC's Mass Jamboree. So that is at JP Mini tomorrow at 11:30 a.m. at the Dominica State College. So that is Jolly's meet and greet DSC Mass Jamboree. That is what is happening tomorrow. I also know that there is an upcoming um, exercise session and people are getting prepped for carnival, Jacinta. I've seen you doing your stuff in the gym. But Cardio Blaze is also on every Thursday until Carnival at 5:15 p.m. Fitness University, of course, that's
it.
Jolly's gym, is presenting Cardio Blaze every Thursday, and the location is at the Old Street Court opposite Patty Shack. So every Thursday from 5:15, you want to get your sweat on, you want to start getting fit for carnival. I don't know if it's maybe too late, but you can
But you
try.
can still do something.
Yes, you can try something. Come out and exercise at Cardio Blaze every Thursday, 5:15. So there's one tomorrow, there's one next week Thursday, and the Thursday after that, leading up to Carnival Cardio Blaze. So make sure you check that out. So all that is Carnival prep.
I don't know about the morning sessions. Should you have to inform us, but I always say when carnival time is approaching, gym membership increases.
Okay.
So you see the increase.
You see the increase at the gym. For me, I go in the morning. I feel it's still slow.
Okay.
I don't know if people waiting for a miracle. I'm not sure. But definitely, people tend to, and it's not just for carnival. It's also a start of the year sort of. Let me try to lose some weight and get fit. And sometimes people kind of fade away by March.
Exactly. I was just about to say that. So then you can tell the difference between the ones who really came for a New Year, revolution, or those who just came, to get in shape for the carnival.
In shape for carnival. But of course, on Health Vibes, as we always do, we encourage constant, physical activity.
Of course.
Make it a lifestyle, choice to do something. Last year August, I got on board with my physical activity, which I had stopped for quite some time, and I started at Fitness University in August, and it has been good so far. It's been good so far. So I think if I can get myself back into the mode of exercising, everybody out there can. So if you're listening to my voice and you're saying to yourself, boy, I haven't exercised in a while, I don't think I can get back on board. Yes, you can. You can. Take it slow and just make a start. Yes. So I see our people popping up. Good morning to you guys. Hazel Ann, good morning to you. Good morning, Andres. Good morning, Nerika. I see people popping on. What we're going to do is we're going to take a short break. And when we get back, we'll introduce our guest. She's been in studio quietly, but she's not a stranger to Health Vibes. We're going to introduce our guest when we get back. So please stay tuned. We will be right back.
Jolly's Pharmacy is bringing vibes to health with Health Vibes. Health Vibes. Each and every Wednesday from 10 to 11:30 a.m. with your hosts, Trudy Kristen, and co-hosts, pharmacists Jacinta Fagan and Leona Jeremiah. Education, information, and a bit of humor. And not forgetting lots of vibes. Jolly's Pharmacy is bringing health and vibes together with Health Vibes. So be sure to tune in each and every Wednesday on Q95 from 10 to 11:30 a.m. Jolly's Pharmacy, leading the way in healthcare.
Introducing Jolly's Pharmacy, brand new website, www.jollies.dm. It's your time to jump the line. Shop now at jollies.dm and have your items delivered in the comfort of your office. No more standing in line. No need to use your lunch hour to shop. Hassle-free shopping, safe and secure. Jollies.dm features rush delivery, 1 hour. In-store pickup, regular delivery, 5 p.m. Cut-off time, 4 p.m. It's your time to jump the line. www.jollies.dm. Jollies Pharmacy, leading the way in healthcare.
And we are back with you. And as we promised, we have a guest with us and we have a very interesting topic lined up. Every month, there are different conditions or different health matters that take sort of center stage in terms of awareness. January there are different awareness campaigns for the month of January. Cervical cancer awareness month is January.
Right.
But another awareness focus is thyroid disease, thyroid disorders. Thyroid Awareness Month is the month of January. And on Health Vibes, we've never taken the opportunity to strictly focus on the thyroid. So we figured who better to help us to do that than our endocrinologist, Dr. Natasha Maxime Fritz. No stranger to Health Vibes,
That's all.
but never about thyroid disorders before. Doctor, good morning to you.
Good morning.
And welcome once again to Health Vibes. It's always a pleasure to have you on
Thank you. Thank you.
because we know when it comes to health education, that is your forte. And I really appreciate that you always take the time to come on with us. So, Doc, first of all, we're talking about thyroid awareness, but not many people may know what is the thyroid? What are we talking about? Where is it located? Why is the endocrinologist to talk about it? So as we, get into the meat of the topic, I want to hear from you that basic background as to what are we here to talk about when we say we're talking about thyroid. What is that?
Okay. Good morning to everyone. Again, it's a pleasure being with you all. Happy New Year.
Yes.
January, the best month of
Thank
the
you.
year.
Oh, wow.
We are still in January.
January people.
It's the best month of the year, so that's fine. The thyroid gland.
Yeah.
Interestingly, many times when I just started practicing endocrinology, I would be halfway through the consultation, and especially with the women, when I'm speaking about the thyroid and I'm right on medications going, then we end in consultation, and they still think I'm talking about fibroids and not thyroid, right? So the thyroid gland is a gland that's located in the base of the neck. If you want to use, for example, the man's anatomy to give you a better idea, it's just below what we refer to as the Adam's apple.
Okay.
Right? So it's at the base of the neck and it's in front of our trachea, what we call our windpipe. Okay? It's a very important gland. The thing about the thyroid gland is that it's quiet. So that's why most people don't even know that they have a thyroid gland. However, when it misbehaves and it malfunctions, it's like a badly brought up child. It goes wild. Right? So that's when you realize I do have a thyroid gland. And it's very, very important. Patients who suffer from hypothyroidism can tell you that they really do have a thyroid gland. Because it can be very troublesome. Good. So it's located at the base of the neck. It has two lobes. And then there's a middle portion we refer to as the isthmus. So it looks in a diagram or in anatomy like a butterfly. Okay. So it's like that quiet butterfly that's flying around and nobody knows that it's there. It's just doing what it has to do. Normally, the thyroid gland is not visible and it's not palpable, meaning that we're not supposed to see the thyroid gland when we look at you externally. And even when we palpate with our fingers, we're not supposed to feel the thyroid gland.
To examine in the
Right,
body.
in
Yeah.
examination.
Right.
So if a patient enters and I can actually see the thyroid gland, or if you're passing on the road and you can actually see the person's thyroid gland, for example, someone with a goiter, or if during examination I'm touching and I can palpate the gland, then that's an alert that something is wrong.
Okay.
So it's a very quiet gland at the base of our neck, and it has many important functions. It's most known for the regulation of our metabolism. All right, so that's its first function. Its main role is the regulation of the metabolism. It's also important to regulation of our heart rate, our body temperature. It's important for our hair, our bone health, skin health, all of those things. And like I said, usually when we have alterations or malfunctions in those areas, that's when we realize that the thyroid gland, the importance of the thyroid gland, right? When it's not functioning properly. It plays a very important role in fertility, also in the regulation of the menstrual cycle, and having a good chance of conception, right? So all of this function, it plays a very important role. A lot of times it's not spoken about, like you said, very often, because it's so quiet and because it's not visible. so we don't speak about it much. But I see a lot of thyroid cases. For statistics, 35% of my patients are patients with thyroid. I'm
Oh.
referring to here in Dominica, patients with thyroid disorders.
Oh,
Yes.
that's a substantial amount. Yeah.
Yes, definitely. So, Doc, for example, if, well, you mentioned that the thyroid gland is responsible for metabolism. So that's the conversion, of the food that we eat into energy. Let's say right now, hype season for getting in shape for the carnival season, but then somebody is not exercising more than a regular and they have noticed a decrease in their weight and nothing else in their life, has been so significant to cause a change in their weight. Or similarly, someone hasn't changed their diet or any other factors in their life that may cause them to put on weight.
And they're gaining weight.
And they're gaining weight. So in this instance, many people may not think of the thyroid gland being responsible for those alterations. What would you advise an individual who may have a thyroid issue and may notice those type of changes and may not be able to think or figure out the cause?
Okay, so this is actually the leading cause for motive for consultation. Weight gain or weight loss. Most times weight loss, sudden weight loss. And that would be in reference to hyperthyroidism and
Okay.
overactive thyroid. So the patients or their physicians realize that they're losing weight suddenly, pretty quick. So when we run the thyroid hormones, we see that they're elevated. So there's an overproduction of thyroid hormone. And then the opposite happens with hypothyroidism, where we have an underactive thyroid. Sometimes we get them confused. So hyper is when there's too much, and hypo is when it's too low. So we have ER and the other one is O.
Yes.
Right? So with the hypothyroidism and the weight, sometimes it takes a little bit of time before the patient
See
or
the
the
change.
physician realizes that the thyroid is the cause, because we are more used to, people panic a little bit more if they're losing weight
Yes, very true.
excessively, because one of the first things that come up in our mind is the C word. So everybody runs when they're losing weight excessively,
Right.
when they're not exercising or dieting, etc. So we're much quicker to catch hyperthyroidism.
Ah.
With the hypothyroidism, we are gaining weight. We might just say it might be our lifestyle, we're more sedentary, etc. But there are other symptoms that are usually associated that I will pinpoint
Okay.
that we could associate, and that light bulb will go up when we know those symptoms, not just the difficulty to lose the weight or the gaining of the weight. And that, as we said, is all related to our metabolic rate, and that is very much controlled by the thyroid gland.
Right.
So when we speak of the weight loss, it's more associated with hyperthyroidism. So there we're talking about HYPER, right? So that's an overactive thyroid. And globally, 2.5% of the world's adults suffer from hyperthyroidism. It's more common in, where you all think is more common, in men or women?
Women.
As usual. So it's more common in women.
Okay.
And the patients, the average age of the patients is between 20 and 50. So the common symptoms, first on the list, weight loss, excessive and rapid weight loss. Because what happens is, with the overactive thyroid, we have a higher metabolic rate and we start shedding, especially muscle.
Okay.
Especially muscle, right? The second motive for consultation, usually I get those patients referred by cardiology, and that's the heart rate, accelerated heart rate, which the patients refer to as palpitations. My heart is beating fast, beating fast.
Yes,
and you
yes,
have
yes.
no reason, you cannot pinpoint any reason, you're not taking any medication or anything that would accelerate your heart rate. So that's the second most common motive for consultation in hypothyroidism. So weight loss, palpitations, and then you have feeling hot, just feeling hot for no reason at all. All of them has to do with the high metabolic rate, sweating, anxiety. So just feeling like spontaneous anxiety. You're just nervous, or you're having difficulty sleeping, you're restless, and you cannot pinpoint what exactly is causing it. And the tremors.
Okay.
So you're just sitting at your desk,
Shaking.
your hands are trembling, or you can feel your legs just trembling involuntarily. All right. So that's
Okay.
one of the signs. Diarrhea.
Mm-hmm.
So as your metabolism is increased, everything is
everything
just passing
else
out through the
is-
system. Quicker muscle weakness, and in terms of the menstrual periods, lighter periods is more
Okay.
associated with hyperthyroidism. So if you're experiencing any one of those symptoms, then you definitely need to get your thyroid gland checked. So
Okay.
these are some of the signs and symptoms of
Hyper.
hyperthyroidism that we see
But
most
doc, it's
often.
it's interesting because you've outlined several symptoms. Several of them, I mean, and that's why I guess diagnosis is so dependent on some sort of lab work as well, because several of them to me may be misconstrued, particularly if it's a woman you're dealing with at a particular age with menopausal symptoms. You spoke about feeling hot, randomly, the hot flashes. You spoke about possible, accelerated heart rate. I know some people have, said in that time of life they may experience that as well. The lighter menstrual period. So somebody might think, well, it's I'm hitting menopause. So as the physician now, let's say a woman is you a woman comes in for consult with some of the symptoms that you've mentioned and the person is of a particular age. What is the differential that you're looking for? Do you immediately just have to do your lab work to make sure?
Right. So that's why it's important to go to your doctor.
Mm-hmm.
Don't just self-diagnose and assume. And I always tell my patients, stop blaming everything on menopause, especially the women, right? Everything is menopause fault, and the thyroid gland, they're doing its thing, and we blame it menopause, right? So it's important to get yourself checked when you feel because there is actually a concrete diagnosis for menopause. We can
Okay.
say if you're definitely menopause or not.
Yes.
So, and this is actually one of the things that we screen when we're looking at a woman in menopausal age, right? The thyroid gland. We take a look at the thyroid gland to see if she's in a hypothyroid or hypothyroid state at that point. Because in medicine, we have something we call differential diagnosis. So if you notice a lot of the symptoms that I presented, signs and symptoms, they fall under a lot of other illnesses, right? So that's where we do a differential diagnosis to determine what exactly is going on. And with the thyroid gland, for the evaluation of the thyroid gland, there are two very important things. One, we have the thyroid hormones themselves. So we have TSH, T4, and T3. TSH is produced in our brain by the pituitary gland, right? It's a thyroid stimulating hormone. And TSH is what controls T3 and T4, which are produced by the thyroid gland itself, which is at the base of our neck, right? So when our thyroid hormones are low, then TSH is going to respond. It's going to increase. It's like our body is telling the brain, we need more, we need more, we need more, we need more. So TSH goes up so that we can have more thyroid hormones. And the opposite happens when we have high thyroid hormones. The body tells the brain, I have too much, I have too much, I have too much. So then TSH decreases. So that's how we interpret the lab work. And also sonography of the thyroid gland is very important, an ultrasound of the gland.
Okay.
And they go hand in hand, but we also evaluate them separately. So, for example, I'm sure you'll see somebody walking on the road with a goiter, with an enlarged thyroid gland. And you may wonder to yourself, but why that person not getting that gland removed now? Why they have it? And then you might know someone whose one was much smaller and they had to have it removed, right? So we evaluate function and we evaluate structure. So someone might have a gland which is in a hypothyroid state, meaning it's overactive, but they don't have a goiter. Structurally, it might be perfectly fine and normal. Whereas you might have someone who has an enlarged gland, right? But it's functioning normally. So we evaluate the function via the blood work, measuring the thyroid hormones, and then we evaluate what's going on with the structure via sonography, ultrasound of the neck and the thyroid gland. I also want to note that in our thyroid gland, for educational purposes, within the thyroid gland, there are 4 other glands, right? So in each lobe, in the superior and inferior levels, we have parathyroid glands. And the parathyroid glands, they're even more quiet. than the thyroid gland. So if you did not know you had a thyroid gland, you're definitely not going to know that you have parathyroid glands, right? So the parathyroid glands are responsible for how we process calcium, controlling our calcium, right? So as we said, hypothyroidism, these are some of the signs and symptoms, and then we do the blood work and so forth to ensure that, to basically concrete the diagnosis. Some of the main cause, I should say first, of hypothyroidism is actually an autoimmune illness.
Okay.
And when we say autoimmune, we actually mean that the immune system is attacking healthy cells in the body. So in that case, it would just be that it's attacking the thyroid gland. And that disease is Graves' disease. 70% of hypothyroid cases
It's Graves.
are Graves'
Okay.
disease. Okay, so it's an autoimmune disease. It can be inherited. So there's a genetic factor there. It's mostly associated with a goiter. So a lot of patients who have Graves' disease do have what we refer to as a multinodular or diffuse, a globally enlarged thyroid gland. Apart from that, we see patients with hypothyroidism who have caused by certain medications, for example, medications that we use to control irregular heartbeats and so forth. The excess use of thyroid hormones themselves. So you may have a patient who was given thyroid hormones for hypothyroidism,
Okay.
and then they convert into
Hyper.
for various reasons. They convert into hyperthyroidism. So that's one of the causes of hypothyroidism. The gland itself and its increasing size, like in goiter, or inflammation, like in thyroiditis, is another common cause of hypothyroidism. Excess iodine intake.
Okay.
Okay. Excess iodine intake is a cause of hypothyroidism. There are some cultures where they use foods that are high in iodine, especially sea-based foods as well. I know you're going to ask me for example.
What are those foods? Because I know,
so for example, in the Asian culture, which is where we have the highest incidence of thyroid illnesses and also thyroid cancer in Asia, they use a lot of foods high in iodine. One of the main foods more related to our Caribbean culture would be the seafoods, for example, like shrimp, seaweed. That's another one that is used in different foods and beverages. And so I'm not really talking about sea moss so much, but seaweed. That's high in iodine. And of course, we have iodized salt.
Right.
Yes.
Most of our salts are iodized salt.
Very true.
And there's a reason why salt is iodized. It's because of hypothyroidism. So back in the days, long ago, there was a lot of hypothyroidism. There was a lot of hypothyroidism in children, which was affecting their neurological development, because the thyroid hormones are very important in the development of our brain and our neurological system, right? So one of the as it became endemic, the quickest solution was to put iodine in the salt. Right? So we have iodized salt. And then a pituitary adenoma. So that means a little tumor on the pituitary gland. Because remember, I said at the beginning that TSH, which is the thyroid, the hormone that controls our thyroid hormones, the thyroid stimulating hormone. If there's a little tumor in that gland, then we can have an increase in TSH, which increases the production of our thyroid hormones. Okay. So when a patient sits with me and they have an increased, I do the blood test and we confirm that it's hypothyroidism. I go one step further to determine what we refer to as the etiology. Why are your thyroid hormones elevated? So it's not just about, okay, your thyroid hormones are elevated, I'm going to put you on medication. I now need to try to see if there's an underlying cause. I need to know if it's Graves' disease that you have, because if you have an autoimmune disease, there are other things that I have to look at. And there are certain things that I have to caution you about. I need to know if you're taking a medication. So for example, a lot of the patients are referred by cardiology. The secondary cause of the hypothyroidism are some of the medications that they're on to treat the irregular heartbeats and so forth, right? I need to know, based on the result that I have, if the cause is really the thyroid gland or if it's up there, the pituitary gland. So That's what the specialty is there for. So we go
Okay.
a little further than just diagnosing and treating the hyperthyroidism.
Thyroidism. Okay.
But Doc, I have a question. So in the situation where hypothyroidism transfers to hyperthyroidism, how do you get a control or a balance so it doesn't go back and forth?
You don't overshoot all the
Yes.
time.
Okay. So the thing, and that's why I said the thyroid gland is silent. And I usually, that's my introduction when I start with the patient, because I have something a little troublesome to tell them after that I know they're going to make noise with me about. Because when you have thyroid illness and we're trying to manage you, at least every 3 to 6 weeks, we have to repeat the thyroid blood test. So that can be a little troublesome and costly for the patient. And that's the reason why is the thyroid gland takes 3 to 6 weeks to basically readjust.
Okay.
So let's say that patient comes in with hypothyroidism, right? And we use, the main drug that we use is levothyroxine, right? Which is thyroid hormones, basically. So we give you that levothyroxine. The gland is going to take 3 to 6 weeks for chemically in your blood, we can see the adjustment to see if you have enough, if you have too much, or if you have too little. So basically, today I put you on, let's say, 50 micrograms of levothyroxine. In 3 to 6 weeks, you have to repeat the thyroid blood test for me. So that's where I get to see if you are on enough, too much, or in excess. So if you're in excess, I'm going to see now that you have converted from, the panel is going to show me that you're no longer in hypothyroidism, you're in hyperthyroidism. So now you have too much, because sensitivity to medications, we know that some people are more sensitive to certain medications, or some people absorb certain medications better, right? So we have to take all those factors into consideration. So if I see that it's too much for you, what am I going to do? I'm going to
reduce
lower
your
the
dose.
dose. But then in 3 to 6 weeks, we have to repeat. So you have to get pricked again. So that's when these patients really realize, oh, I really do have a thyroid gland. So you have to get pricked again so that we can evaluate to see if the dose is correct, because either spectrum is dangerous.
All right.
Being in hypothyroidism is dangerous, and being in hyperthyroidism, there's a common complication of hyperthyroidism, which is the thyroid storm, and the thyroid storm kills.
Okay.
The thyroid storm has been responsible for many deaths and for people going to ICU. Okay, so and then we have the hypothyroid coma, where patients literally go into a coma because of low thyroid hormones.
Okay.
Right? So it's very important to measure and to evaluate where you're at.
Okay. Doc, you said two things I want to kind of zone in on a bit. As it relates to hyperthyroidism, you mentioned at least 70% is caused by an autoimmune disorder, Graves' disease. If somebody has another diagnosed autoimmune disease, is it likely that they could have another one, such as Graves? So if you already, you have systemic lupus, or you have, whatever autoimmune disease you may have, is it rheumatoid arthritis, something? Is it like somebody should be thinking to themselves, boy, maybe that could happen to me as well? And then you also mentioned the genetic kind of linkage that is there. So if you have a family member that has hyperthyroidism, for instance, that is what we starting off with, should you also be kind of conscious, oh, something could possibly go wrong with my thyroid? So those are the two questions.
All right, and your questions answered themselves. So yes to both of them.
Okay.
Right? So, and that is one of the reasons why we go a little further in endocrinology to determine the underlying cause.
Okay.
Right? So if I know that you have Graves' disease and it's an autoimmune illness, I usually tell the patients that any other symptoms they feel, for example, if you're developing a rash on your skin, any other thing that you feel, that you have to let me know, because I need to know if it's just the thyroid or if you have another autoimmune process going on. So yes, they are related and they can interpose. And that is one of the main reasons why we try to rule out with hypothyroidism Graves' disease, so we can properly study that patient. And if anything else pops up, we know that we have to look at other autoimmune processes. And then the genetic part, yes. So if in your family you have someone who has had, let's say, a goiter or any one of the thyroid disorders, hypothyroidism, hypothyroidism, thyroid disease, any one of the thyroid disorders, and especially thyroid cancer, then you do need to get screened. And like many or almost all of the illnesses, it can also be asymptomatic, meaning you don't present any symptoms. That is more common with hypothyroidism than hyper. So hypothyroidism is more symptomatic, but you could be in a hypothyroid state with low thyroid function, and the number of patients who walked into to clinic, right, and they have absolutely no idea that they have a thyroid issue. They just mention something, and a little light bulb goes on in my head, or I see them from afar. Sometimes they some people walking on the road or they come in for something else, and I just realize, but that thyroid looking a little, and it's not a large goit so that anybody else will see. But because I deal with it on a daily basis, I spot it very quickly. That thyroid not looking normal. And then I just randomly say, I can palpate. I explain and I palpate, and then I do, and then they find out they have. And then, sometimes when something happens, that's when we ask questions.
Right.
So I tell them, you need to find out in your family if you all have any thyroid issues. Immediately they tell me, no, nobody haven't got thyroid yet. And when they go back and they ask questions and they realize somebody had thyroid, somebody had a goiter, somebody died of thyroid cancer years and years ago, right? So yes, there's a genetic component to it that we have to be aware of. So you could, if you do have a history of thyroid illness in your family, you would need to add that to your, when you do your yearly screenings and so forth, you would need to add that to it.
So, doctor, many times we advise our patients or individuals to do your tests, so like pap smears, your mammogram,
your screening,
just your screening test, just to see, if something may be caught early. But with the thyroid gland, well, I guess we can answer after the call. Would you advise just for a regular, your routine yearly checks to do a screening, even though you don't have any symptoms or any reason to proceed?
If you do have, especially if you do have a family history of thyroid illness, then it should be added to your yearly workup. If you don't, I would advise maybe like every 5 years. If you're asymptomatic, at least every 5 years to get it checked. For the older patients, I would, at least above 65, I would add it to the yearly checkup. And then to the women, that's part of preconceptive care. The women who are planning on getting pregnant, especially if you have menstrual irregularities, then definitely you have to do thyroid panel. Because even low thyroid hormones during pregnancy can be dangerous, and it can affect the development of your child.
Okay. I noticed we had a caller. Caller, you can try again. Let me just give the numbers: 449-3095, 449-3096, 449-3097, and 616-4257. Of course, if you're calling from overseas, the number is 305-432-9624. And do we have the caller? Yes, so the caller is, no, we've lost the caller. So caller, you can try again, but I see some questions coming in and we'll try to take them as well. Doc, we have one as it relates to thyroid disease and this diabetes. We'll take that after. Let's take this call. Caller, good morning.
Hey, good morning, Trudy.
Hi, good morning.
Good morning to Zafin, and
Morning.
to the criminologist in the house. And Happy New Year to you all.
Happy New Year.
Thank you too.
Yeah, great program today, and I think right up my alley in terms of what I experienced. Let me say that I have had an attack of hypothyroidism somewhere about 2010. Yeah, I had no idea what it was until I got tested and realized my T3 and my T4 levels were very high. So I was on some medication for that, and then started to do some natural stuff, and I was okay. But lately, in December there, but I must say, let me put that on the table. It might be genetic because my mother also has thyroid issues. Yeah, so I want to put that on the table. So lately there in December, I start feeling some strange things and thinking that, okay, it might be dehydration, it might be this, so I doing what I need to do. I went to the doctor, checked prostate, doing all the things I need to do. But within the past 2 days, I realized I have a condition, something called tachycardia. the endocrinologist, you have an idea, right?
Yes, yes.
All right. So I have what you call for my own monitoring, more than 100 beats per minute in terms per second in terms of my heart rate. And then I come to the conclusion that I might be having a thyroid attack disorder as I speak to you. Yeah, I'm saying that because the first set of symptoms that I got in 2010, what I'm getting now is totally different, but I still want to link it to that because I know my body. And what is actually happening has to do with the thyroid. But the fact that you have in that program, I say, very timely for me because I was thinking of going to one doctor who I think might be just a general practitioner, and you ask the endocrinologist, which would directly relate to my situation. So I like to do this specially. So yeah, so the question there is, I need number, I need address, I need to see you because I know where I'm at already. It's just to get things concretized and deal with the situation.
Okay. So
Yeah.
Doc will share that. But
Yeah.
yes,
Well, after all, yeah.
yes, but you're right.
I just want,
The
yeah,
specialist
but
is who you need.
Yes.
yeah, but honestly, a very, very great program, and quite a few people suffer with these things and have no idea
Right.
what it is. And then that's the thing now. People actually don't get themselves checked, and that's where we kind of lose people, and people go way down low before they can get back better, and stuff become chronic, and sometimes even cancerous. So I'm really grateful for that program, not because of me, just because that you putting the information out there for people to really understand what they're doing. Because I've been there, like I said, in 2010, so I have an idea what's happening to me right now as I speak. And more than that, besides the genetic side of it, I think the first time I got it, it was triggered because of a particular type of stress. And now it may be the same thing because there's family stuff going on, there's personal stuff going on, so the stress levels triggering that, and you get quite a few hormonal imbalances, pituitary gland, hypothalamus gland, everything going crazy. So I understand where I'm at. I just grateful for you, the endocrinologist, who is giving the information, and it just let me light a bulb in my head. I need to be seeing you. Have a good day.
Thank you. Thank you. Yes. So we were discussing, Doc, and as I said, you will share some contact details. I know you do clinics all over Dominica, so you will share some contact details later. But we were discussing this. We started with hypothyroidism. The caller mentioned hypo, and I know you were going to go into that. I see someone asking here about the thyroid affecting diabetes, and they know of people who have lost weight due to diabetes issues with thyroid. So, Doc, I'll allow you to comment on that before we delve into the next issue, the
Okay.
hypothyroidism.
So in reference to the call,
Mhm.
so that's an individual who needs like today
Mhm.
to go get his thyroid panel done, TSH, T4, T3, because he's most, especially as he has a personal history, he's most probably in hypothyroidism. Okay. In reference to the question with diabetes and thyroid illness, thyroid dysfunction is much more related to type 1 diabetes, which is autoimmune
Right.
diabetes. Okay, so there is a link and a relation there via studies, especially with Hashimoto's thyroiditis, which we will see in hypothyroidism, and type 1 diabetes. There could be a coincidence that someone is suffering from high thyroid dysfunction and diabetes at the same time. And that's actually one of the things that I screen for if somebody comes in. Remember we spoke about the differential diagnosis. So that's one of the things that we screen for if someone comes in with sudden excessive weight loss. So we screen for blood sugar issues, and we also check the thyroid one time to ensure that it's behaving itself, because it could be both of them together. Now, if you suffer from hypothyroidism and diabetes, then we can see the impact of the decreased metabolic rate in your glucose, your glucose numbers, your blood sugar numbers. Because if you have a lower metabolism, your body's processing things slower, right? Absorption and all of that. And then that could impact your blood sugar levels. So there is, in that way, there is correlation.
Doc, so as we we go into that, I personally, of course, and I've said this before, I have polycystic ovarian syndrome, but I've gained, and I know, about the issues surrounding that. But because of weight gain, I have done thyroid screening so often because I've told myself before, I have PCOS, but I maybe have hypothyroidism too, I'm sure, because it cannot be I am gaining weight like that with no, change as far as I can see in terms of nutrition and activity. And I'm gaining it. I'm like, okay, so I'm going in, and I've done this multiple times because I also have a genetic, a genetic history. So I am convinced, doc. So as you mentioned, of course, occurrence of certain hormonal issues. I think that is interesting because sometimes for certain things, people may really convince themselves, like I did a few years ago, is that because I'm reading hypothyroidism is weight gain. I see I have a genetic link there, and I'm going and I'm doing blood work. I've done this at least I've done this at least 3 times to check my thyroid because I say, it must be, it must be. And all 3 times I think I've done that, it has been fine. But going into that now, somebody's gaining weight, or they feel sluggish, which is what I think I was feeling too at the time, sluggish. Yeah, what is the thought process? Not Trudy and her excessive testing, but what should be the person's thought process?
So these are actually the two you mentioned are the two top symptoms for consultation. So that's weight gain or difficulty losing weight, and fatigue, like that tiredness that you don't understand where it comes from, or you're just feeling sluggish. It could get so bad that even the person's speech is slowed. Everything just becomes slower. They even move slower, depending on how low the thyroid hormones are. Your thought process, you find that you're forgetting quickly, you're not able to process things as well as you used to. It's quite like the opposite of hypothyroidism. Right? So you may sit with someone who has hypothyroidism, and they're there, and it's like they're fidgeting, and they have tremors, and they're talking quickly, and they're hyperactive, and they're standing up, and they're all over the place. And the hypothyroid patient is the opposite. Like they have absolutely no energy. They're just slow, and they may have difficulty processing their thoughts. In hypothyroidism, they're always hot. Even when it's cold, they're complaining that they're feeling hot. The hypothyroid patient is always cold.
Okay.
Right? So they're always cold, and they will not be able to stand the AC for you because they have that excessive, sensitivity to the cold. Dry skin, hair loss. That's another common sign that we see. And if in hypothyroidism we have diarrhea, what do you think we have in hypothyroidism? Constipation.
Okay.
Right? So constipation. Right. And then heavy or irregular periods. Right? So these are some of the more common signs and symptoms of hypothyroidism. Now, like I said, people run quicker when they experience the signs and symptoms of hypo.
The weight loss and so on.
Or they may be more quick to think of the thyroid gland, like the physicians, in hypo. But the symptoms of the hypo might be, a little more. So we don't usually the physicians take a little bit more time or the patient takes a little bit more time in consulting. Because if you just tell, let's say, your family member, boy, I'm feeling tired, what they're going to tell you? You need to rest.
Yes.
Or you're stressed about something, get some sleep. Nobody's thinking about the thyroid gland. Right? So it's important if you have excess fatigue, like it's like you're just low on energy, and you can feel it mentally. It's important to get your thyroid function checked. And then, just like in hypothyroidism, the leading cause was an autoimmune illness, is the same for hypothyroidism, where you have an underactive thyroid. And the name of that illness is Hashimoto's thyroiditis. Okay, it's an inflammation of the gland. A lot of times now, Hashimoto's thyroiditis, here's a fun fact, starts off because it has 3 stages. Not all patients go through all the stages. Everybody goes through phase 3. But a lot of times it starts off in a hypothyroid state. So you start off with hyperthyroidism, then you fall, because what happens in Hashimoto's thyroiditis, it's like the immune system attacking the gland, and what it does is breaks down the gland. So you start off when it's breaking down at first, you have that release of the thyroid hormones. So it's like you exhibit symptoms of hyperthyroidism. Then you fall into a normal thyroid function state, and then you fall into chronic hypothyroidism. So basically, almost like the rest of your life, you are in a hypothyroid state. So that's Hashimoto's thyroiditis, the leading cause of hypothyroidism, and it is an autoimmune illness. So it's basically like the opposite of Graves' disease.
Graves',
It's
okay.
like the opposite of Graves' disease, right? Other leading causes that we see in consultation: thyroidectomy, okay, as a consequence of surgically removing the thyroid gland. Now, that too could be that you had to remove it because you had hypothyroidism, or you had to remove it because you had a very large goiter, or you had to remove it because you had thyroid cancer. But then when we remove the gland, then the gland is no longer there to produce the hormones for us. So what happens? We fall into hypothyroidism. So if anyone has had a thyroid surgery in the past where you've removed maybe a nodule, you removed a lobe, because you could have a partial thyroidectomy where we only remove part of the thyroid gland, or you could have a total thyroidectomy where we remove all of the gland. So either of those, then you need to check your levels to ensure that you're not in a hypothyroid state, because if you are, that could lead to further complications, right? So the surgeries are one, and then the iodine deficiency, which would be the opposite of what happens in hyperthyroidism when we have iodine excess, right? So these are some of the things. When we look at the differential diagnosis, these are some of the things that we look at. The testing is the same. Basically, we look at the thyroid hormones, we look at the sonography to see how the thyroid gland is, and then we look at there was a patient I had maybe about 5 months ago, and I don't know why a sonography was never done, but that patient has been in hypothyroidism from childhood.
Wow.
And when we did sonography, the thyroid gland probably was maybe like half of a finger, very, very small compared to its actual size. So they had an atrophic thyroid gland. And that was the reason for the chronic hypothyroidism. Right? So like I keep reiterating, the blood work and the sonography. So we evaluate function and structure. And the main treatment for hypothyroidism is levothyroxine.
Okay.
Basically the medication that we use to replace thyroid hormones.
Doc, I'm going to take this call. Right before I take the caller, I just want to plug in. If somebody has a thyroidectomy, wouldn't the physician have put them on medication automatically, like without them having to, monitor? So I just want to stick up in that. But let me take this call. Caller, good morning.
Morning, Judy. Morning, Jacinta. And morning to Dr. Lassie.
Morning.
Judy, a nice topic, but all I call to say is that we need another session. She need to come back some other time because she gives a lot of information there. And I don't think we can grasp all that in one session.
Okay.
That's my view. And so probably she need to come back in another session sometime. And, take it easy. Take it because a lot of information she giving us there. That one session there, Judy, we need another one. Thank you.
All right. Thank you, caller. Well, it's a privilege when we get the doctor in the house, because the doctor is very busy. So sometimes when we get her, we have to try to squeeze. You have to squeeze a lot of information. But yes, I take that point that, and as I said, we had not discussed thyroid disorders on the show before in any sort of depth. So it will be something that we will have to revisit to continue the sensitization as we move along. But yes, Doc, if somebody had, you removed a nodule or you removed so what wouldn't medication have been prescribed?
I wish I could answer yes. The polite answer would be yes, of course. But no.
Okay.
Sometimes it's missed. All right, so sometimes it's missed. I get that a lot. Patients coming in after partial thyroidectomies, or probably the physician just assumes, well, since we didn't remove the entire thyroid gland and everything will be okay. Or some
So it's
patients who do not
partial.
follow up,
Mm-hmm.
we do not follow up with their physician. So they did the surgery and then they're feeling okay. So they, especially with hypothyroidism, they're not really paying attention to that until something, the light bulb goes on.
Mm-hmm.
So there are different reasons why some patients may not be placed. No, especially with partial thyroidectomies, it doesn't always mean that the patient needs hormone replacement.
Okay.
Okay. So, for example, there is something called thyroid compensation, where one gland, in the absence of the other, increases its production to take up the responsibility of the other gland, which is not there.
Mm-hmm.
Right? That is actually one of the leading causes of a partial the goiter on one side or thyromegaly. So some people, for example, who have had one lobe of their thyroid gland removed because it was enlarged or they had nodules, they may notice over time that the other lobe is increasing in size.
Okay.
To compensate.
So what it
Mhm.
does, right? So we call that compensatory hyperplasty. So the gland is basically the tissue that's left is actually increasing in size to make more thyroid hormones because we took out the other side,
Mhm.
right? So not everyone who has had a partial thyroidectomy needs, but I could say about 99%, if not 99.9% of the patients who have had total thyroidectomies have to be supplemented with medications. Yes.
I really want to interject here to encourage patients who have just been diagnosed and just gotten a new prescription for levothyroxine to follow up when they need to. I'll continue after the call.
Okay, let's take a call. Caller, good morning.
Yes, good morning.
Good morning.
I was wondering if you all would ever have a program like that. And I'm hearing that this morning. Thank you very much. Because I am one who had my thyroid gland taken off in 1996.
Mm.
And I'm on thyroxine.
Mhm.
What I want to ask, how can a person remain on that for a lifetime, or there is a certain period of time you have to stop? I want to know.
Great question. Thank you, caller. Yes,
Yeah,
doc.
and another thing,
Okay.
another one.
Okay.
Another thing. I take my blood test every year. I'm taking my blood test, and every time I take the blood test, it is okay. So is the blood test supposed to be done every year, or can it be done every other year?
Okay.
All right. Thank you.
Okay, thank you, caller. So 2 questions, doc.
Okay. So with this patient, the first thing I would ask is, why was your thyroid gland removed?
Mm-hmm.
Okay. So there are many reasons why the thyroid gland could be removed. Some people remove the thyroid gland because they have a goiter, and though it's functioning properly, which I do not recommend that you remove it if it's functioning properly and you have no compressive signs, but just for aesthetics, for how it looks,
Yes.
they opt for removing it, right? Some people remove the thyroid gland because they have thyroid cancer, so it has to be removed. Some people remove the thyroid gland because they have a multinodular goiter and they cannot breathe properly, and they have difficulty swallowing because it's compressing everything there in the base of the neck, and so it has to be removed. So that would be the first thing, because each one, there's a different pattern and protocol for following up, right? So let's say the patient had, from what she expressed, it seems like she had a total thyroidectomy in 1996.
Mm-hmm.
And then she does her thyroid workup. I would
Every year.
imagine that a physician interprets those results,
Mm-hmm.
and I would imagine that she's supplemented with levothyroxine because she's asking how long does she have to be on the
Mhm.
medication. If she had a total thyroidectomy, she's most probably going to need to be on that medication for the rest of her life.
Wow.
Because remember, we remove the gland
Exactly.
totally,
Yes.
and the thyroid hormones are basically essential for survival, right? So she's going to need to be supplementing. There may be periods in her life where she may need a lower dose, and that's why it's important to do the blood test to check up. She may need a lower dose, and there are periods in her life where she may need a higher dose, right? Based on each particular case, then there is a protocol for how often you're supposed to check up. If she's checking up yearly, I would imagine that the dose of levothyroxine that she's on right now is adequate. So she has a yearly checkup. But if she comes to me and I see that she's still in a hypothyroid state on, let's say, 100 micrograms of levothyroxine, then I'm going to need to increase that dose, and not in a year's time, but in 3 weeks to 6 weeks, she has to repeat that test for me to see if the dose is now adequate. So it depends on the situation. Patients who have had thyroid cancer, we go beyond the thyroid panel, because one of the things that we want to ensure is that during the surgery, absolutely no thyroid cells were left. Because there have been cases of patients who have had thyroidectomies with tissue or cells being left behind with the stimulation. Because remember, when you take out the thyroid gland, you didn't take out the gland that producing TSH, up
In
there
the
in the
brain.
pituitary, right? If you didn't, we didn't remove the pituitary gland, so you could still have sensitivity of the remaining tissue to TSH, and then those cells multiply, right? And then you could still have a cancerous process going on or reoccurring. So there are other tests that we do to ensure that we don't have any thyroid remnants in there. So that also is important. So it depends on the underlying cause for why the thyroid gland or part of the thyroid gland was removed. That would determine how often you have to do your checkups. And then, depending on the function, the results that you present, that will determine how often, for how long you have to take the medications.
Okay. Okay.
I really love the breakdown, Doc, and I hope that our listening audience really take the time to understand that it is not just a one road process. And as you explained, if you have the total removal as opposed to the partial, and the process of the TSH, and going forth. But what I was explaining before, and you also hit the nail on the head, of the importance of returning to do follow-up testing, because we do have situations where patients come in with their book, we realize, okay, the medication was only prescribed for a certain amount of time and they have elapsed. So probably a couple of weeks have passed, past that date. And they say, but the doctor said I have to be on it for since I had this procedure done. But yes, but we cannot just refill. You
Right.
need to go back, because as you explained so well, the tendency or the possibility of changing a dose, a strength, and we cannot just refill based on the initial dose.
The old prescription.
Right.
Yeah.
So I really want to caution our patients, just work with your doctor. It is for your health, and something may need to change. So follow up.
And before I forget, I want to highlight the role of the ENT specialist in managing the thyroid gland, right? So before I was on island, the thyroid cases were really totally managed by the ENT specialists, right? Their role is, so in endocrinology, we do the hormonal function, and they deal more with structure. So for example, if the ENT specialist is seeing someone with a goiter, right? What they would do the thyroid workup, and then endocrinology manages the balancing of those hormones. So usually I get patients referred from ENT, and I refer patients to the ENT specialist. Let's say I have someone who has hypothyroidism or and then we need to do surgery, or they have signs of compression, they need to do surgery. So I'm going to refer them to the surgeon, which in this case would be the ENT specialist. So we work hand in hand in managing the thyroid disorders.
So the ear, nose, and throat specialist. We've had Dr. Pascal on the show before. Let me just
Yes.
say good morning, because I'm
Yes.
trying to get him back as well. So IP, good morning to you. Let's take a call. Caller, good morning.
Good morning.
Good morning.
Hi, good morning.
Recently, my family were inflamed with my brothers, with people, and they were all normal. But my vitamin D, they were very low. So what could be the reason for inflamed thyroid?
Okay. Thank you. Yes, I was going to take that. I was going to take that
I saw the
question.
question.
Yes, I saw it come in. Yes. So inflamed thyroid, blood work showed T3, T4 were normal, but vitamin D was low. So what could be the
Okay, so that's a
reason?
perfect example of function and structure.
Mhm.
So what she's actually saying is that she had normal thyroid function, meaning that the hormonal levels were normal, but then structurally something was wrong. So she's referring that she has an inflamed thyroid or thyroiditis. So this patient, if she has not done her autoimmune studies, that's one of the things that she has to do. So I need to rule out that she has Hashimoto's thyroiditis. That's number one, where we could have that chronic inflammation, but it doesn't necessarily mean that the patient is in hypo or hypothyroidism at the time. Now, remember I mentioned, and that's specifically why I brought it up, because I know that question was going to come. Remember I mentioned the 4 little glands in the thyroid gland, the parathyroid glands, who are responsible for the metabolism of calcium and vitamin D. Okay. Now her low vitamin D could just mean that she probably doesn't get in much sunlight. Right. It sometimes has absolutely nothing to do with the parathyroid glands. But in evaluating the thyroid gland, especially when there's thyroiditis, because remember, think about it. If the entire gland is inflamed, and then there are 4 other little glands in there, right? Those glands probably could be affected also, the parathyroid glands. So with patients with thyroiditis, especially Hashimoto's, we also screen to see if they have parathyroid dysfunction, which expresses itself with alterations in calcium and vitamin D. So she would need to get screened for that also.
Okay. All right. Okay. So we were going down the line of thyroid disorders. We've spoken about hyperthyroidism. We've spoken about hypothyroidism. And Doc, you've mentioned quite a few times goiter. I did see that we had a listener earlier on mentioning that they had goiter and the removal goiter operation over 40 years ago, which affected their vocal cords. Before they could sing very high, they were soprano before, and now they cannot sing a note. So my next line of questioning is related to goiter. Is it something that you see a lot, and what is the causation behind that?
I love that we're having those questions, because they're day-to-day examples of things that I see in consultation, and then I can use it as an example to reiterate what I'm saying, right? So, and that's one of the reasons why in endocrinology, and sometimes different specialties, sometimes we clash. So the surgeons, you all know surgeons like to cut. So for example, we have a little back and forth with the ENT specialists, because a lot of times, a lot of doctors, from the time they see a goiter, is let's go
Take
surgery,
it out.
right? But then there are criteria. There's a set of criteria that we have to look at for whether this patient really needs a thyroidectomy or not, right? Because the surgery itself comes with its specific complications, possible complications. Doesn't mean anything is going to happen to you, but there are possible complications. One of them, remember, because of where the gland is located, it's so close to your larynx, to the voice box and all of that. That's one of the complications that you may have. So it expresses itself if that voice thing is present, or as a complication. You could have hoarseness. Some people actually do totally lose their voice. Okay. Now, most times the doctors, especially the ENT specialists who have had years of experience and so forth, they're very good. They're very good at it, because it's their field of specialty. So they know, they go in very carefully, and they're careful. And if there are cases that are very complicated, so for example, we've had patients who have had endothoracic goiter. What that means is that the goiter is not just growing from back to forth, but it's growing down into the chest. So, for example, these cases, they're not operated here in Dominica. We send them overseas, because we would need thoracic surgeons along with the ENT team, right? So it all depends on what we see going on structurally. So you could have, during the surgery, the affectation of the voice box, you could have bleeding, and then you have the post-operative complications, for example, chronic hypothyroidism, where you may have to be on medication for the rest of your life to compensate. So we don't like to touch the gland surgically unless it is absolutely necessary. Yes.
Okay.
So
yeah, you asked about the goiter and so on. So goiter
Causation.
basically, yes, the goiter is basically, it has the same causes that would fall on the both hypo and hypothyroidism. So most times we relate a goiter to an overactive thyroid, but you could actually have an underactive thyroid and have a goiter, right? So it falls both under hypo and hyperthyroidism, especially if the cause is autoimmune. So when we say goiter, we are basically talking about an enlargement of the gland. It's bigger than it's supposed to be,
Okay.
right?
Okay.
And most times that's visible,
Mm.
right? So we can see it. Then any enlargement of the thyroid gland, we can refer to it as goiter. The goiter can be diffuse, meaning the entire gland is enlarged, or you could have a multinodular goiter. A multinodular goiter is like you have a stone and it has bumps,
Okay.
right? So it has lumps, it has humps. So that's what we refer to as a multinodular goiter. And then you can have just a nodule. So usually when I send patients to do their ultrasound and they read it before they bring it back to me, they see nodules and they panic. So the nodules are basically like specific areas in the gland, right? Where you have the lumps, the humps. So not the entire gland is enlarged, but then you just have a few nodules, or you might have one specific, a solitary nodule. And it could be that that nodule is just there and the gland is functioning properly, or it could be a toxic nodule, meaning that in that area there we have an overproduction of thyroid hormones. So you would have that nodule with a hyperthyroid state. And it's important. One of the most important reasons we indicate the sonography is to look for signs of malignancy, meaning to ensure that it's not a cancerous process going on. So based on the characteristics that we see in the ultrasound, if we see characteristics of malignancy, there's a probability it might be cancerous, then we send you to do a biopsy. Okay, fine needle aspiration of that area to see if there's anything cancerous. The last global statistic that was done on thyroid cancer was in 2021, and there was a report of approximately 2 million cases. Interesting fact in that, like I said at the beginning, 70% of those cases were from Asia. Okay, because of the
diet,
environmental radiation.
Okay.
They noted when they themselves did their studies, environmental radiation was one of the causes, the high iodine intake. And then, in Asia, they're very advanced with the health studies and so on. So the more screening you do, obviously you're going to discover more cases. So that led to why they have greater prevalence there. For thyroid cancer, mortality is low. Okay, so death for a thyroid case or thyroid cancer, once it's caught early, treatment is given, thyroidectomy done, and so forth, there is a high chance of survival. The mortality increases if it is late. Like, most of the other cancers, if it's diagnosed late, if it has already metastasized to other areas, and usually it's within the same age range like the other thyroid disorders, between 20 and 55 for diagnosis. There are different types of thyroid cancers. Some are more aggressive than others. So when we do the biopsy will specify to us, give us an idea of what type of thyroid cancer it is. And then we know, okay, well, we can just treat that with a thyroidectomy, or we can just treat that with some chemotherapy or some radiation or radioactive iodine, etc. We can treat it that way. And then we know in certain cases where we just have to run, because there is one which is this anaplastic thyroid cancer. It's very, very aggressive. So we know that we have to treat it. You may ask, what are the signs that I may have thyroid cancer? Because it's not like breast cancer or cervical cancer that we speak of so frequently.
Often,
so we are quite aware of the signs and symptoms. The thing is with thyroid cancer, and that's what makes it tricky. At the beginning, in the early stages, usually there are no symptoms. And then as it progresses, you may have the swelling of the neck, like the person may feel like they're developing a goiter, right? You have the swelling of the neck, hoarseness, right? That hoarseness are just not going away. It's almost like after when you have the flu and your voice is, but it's just not going away. And it's also associated with that dry cough that you have that's just not going away, right? That could be thyroid. That's one of the symptoms of thyroid cancer. Difficulty breathing and pain. That's one of the specific things with especially with the swelling of the neck and the pain, the extreme tenderness at the just the moving of the gland, like talking often, and the gland moves and so forth, then you can feel pain. And then also in palpation, then you feel pain, because most times, except if the person is really in a state of hyperthyroidism and that gland is really inflamed and overproducing, most times you may see people with the largest goiter ever. Most times it's not painful. Like you can actually go and palpate the gland and so forth, and it's not painful. So when it's painful, clinically, when we examine, then it's an alert to us that we have to rule out malignancy.
I wanted to, I mean, our time is coming quickly to an end, but just in terms of just in terms of clarification, Doc, we talking thyroid. Sometimes people say, I have a gland in my neck and it's hurting. I have glands. They maybe have a flu and some glands pop up, and that is the word that's used. Glands, glands in my neck. I just, as we're wrapping up this discussion, for you to give a little clarity on what are the glands people saying they have in their neck that's hurting when they are sick.
The lymph nodes.
Let me tell you, Doc, you don't know how much. I mean, I'm asking the question because in me teaching human A&P for years, you don't know how much fight I've had to fight with students to determine that lymph nodes are not glands. Like, this has been, I think, maybe one of the hardest things, because culturally that's what we say. Glands in my neck, and I have hurting glands. That is just, but lymph nodes, not the thyroid.
So the lymph node is not the thyroid. The thyroid is in the base of the neck. We have lymph nodes basically all around. So we have it on the hair, below chin area. We have it even behind our ear, coming out. So they form a chain and they go all around the neck. And usually our lymph nodes enlarge and inflame when we have some form of infection, or we have had. And it's actually, I usually tell people, it's a good sign, because it means that your body is
It's
actively working
Properly,
and
yes.
fighting and trapping everything that has to be trapped. And sometimes what scares people is that sometimes the lymph nodes stay, what we refer to as adenomegaly, it stays enlarged for a while. So they feel that thing there and they're constantly palpating it, and they feel it there, and months passing and it's still there, but it doesn't necessarily mean that something is wrong. And if it's something that we have to look further into, the physician knows what characteristics to look for to see if it's something that has to be, let's say, get a biopsy done or so forth. So it's the lymph nodes and not the thyroid.
And not the
gland.
thyroid. Okay,
Yes.
just to clarify. Yes, just in fact, I think you're going to ask something.
Yes, I was, and then doctor went right.
She
into
answered
the
it?
discussion with the thyroid cancer.
Okay.
Because I was going to ask, is it something that can be detected? If you as a doctor physically examining, and then because there are asymptomatic patients, how would you know if someone is developing thyroid cancer? And then you went nicely into the discussion, and if the person has existing symptoms based on what you see, based on the test, then you'll go deeper, and then you went through it nicely. So you answered my question I had in mind. So thank you.
Doc, we are at the end of our time. It's already 11:52 a.m. I wanted to, of course, allow you to leave us with some closing remarks, including where can people find you? I know the first caller did ask. So as we wrap up the topic, of course, to this month, as we started off by saying, is Thyroid Awareness Month. And so we've spent the hour and a half discussing thyroid disorders. I know some people feel like we need to do a repeat. So we will look into that, because there is a lot. But Doc, just to give you the opportunity to close.
Okay. So I want to reiterate the same thing that I reiterate every time I come here, which is important to get yourself checked.
Yeah.
Don't wait until a light bulb has to go on, because when the light bulb goes on, that means something is wrong, right? So don't wait until something is wrong before you get checked. And if you've never done a thyroid test, then just go ahead and get one done. Right, just to remove that doubt from your head, especially if you have a family history. It's as simple as walking into any of the labs and requesting a thyroid test, or asking your primary care physician in primary health to write it up for you, or your private physician to have it, so you could have it done, get your blood drawn, and have your thyroid function done. If you present any of the symptoms or signs that we mentioned, it's important to get yourself checked. In terms of where you can find me, I am the easiest doctor to find, but I'm also the hardest doctor to find because I'm everywhere. So I visit every single one of the health districts on a monthly basis from Capuchin to Kashaku. So you could just walk in basically to any one of the health centers and request an appointment. And don't complain that the appointment is too far, because I have patients coming from overseas and booking appointments because overseas the appointment's too far. Right? So you just patiently wait until you see me. And I will put more information in there in the chat for anyone who wants to reach me. So let's just be proactive about our health. I'm happy that we got to talk about the thyroid gland, because usually it's neglected. So everybody's worried about diabetes and PCOS and all of that. So we give thyroid a little attention today. So I'm happy about that. And I know that we learned a lot today. So it's basically just putting what we learned into practice, right?
So now, at the end of this program, people should know where's the thyroid gland, what it does, and who to contact if you have an issue with the thyroid gland, right? So just in I know there are some products of the week on the table at Jolly's in line with Thyroid Awareness Month. So if you want to tell our listeners.
So very quickly, in terms of thyroid health, we do have a selenium and we have a kelp. Kelp is a natural source of iodine, but as our physician explained on the program today, you have to be careful with the levels of iodine. And with selenium and other supplements over the counter, based on the type of thyroid condition that you're treating, if it's hypo, you have to be very careful, because if you are already taking levothyroxine and you take a supplement to increase your thyroid hormones, then you are in problems. So before just taking any one of the supplements on the shelf for overall thyroid health, or to increase your thyroid hormones, please seek consultations with your physician.
Yes.
Okay?
Yes, definitely. Always do that. So it is the end of the program. Thank you to our guest, so Dr. Maxime Fritz, and congratulations to her as well. I had to say that on the program. Congratulations to her, and she knows why I am saying that. Thank you for coming on the program, and of course gracing us with your presence and educating our listenership and us as well so excellently on this topic. So until I harass you again to come on, thank you so much. And we're signing out here from Health Vibes. God willing, we'll be back on again with you next week, Wednesday, to bring you a health talk show with a little vibes, a little education, a little humor. But until then, do have a good week, and we will see you again. Goodbye.
Take care. Bye-bye.
Woke up this morning feeling real stink. I had temptations to call in sick, but